The next major area from epidemiology you're likely to confront in your exam regard research study designs. I can pretty much promise you'll see questions on research study designs. And more than that, I can pretty much tell you what the questions are going to be. They're going to give you a long description of a research study design, what the researcher did, how they conducted things, some results. And then they're going to ask you one of the following 4 questions. They're going to ask you, question 1, what type of study design is this? Question 2, how would you analyze data that come from this study design? Question 3, what type of bias, if any, is in this particular study? And question 4, how would you fix the bias? Sometimes question 3 is hidden in, what should the researcher conclude about this study? And the first thing you're always looking at when you read a study is the presence of bias. Sometimes question 4 is hidden in, if you did this study again, how would you do it differently? All of that is a question about bias. What do you do to improve it? What do you do to get rid of the bias? We're going to spend our time talking about how you're going to answer these 4 questions. Talking about, first, types of research study designs. I want to begin our conversation about research study designs with a simple but key distinction. See, there's 2 basic classes of research study designs: observational studies and experimental studies. Please note experimental studies are also referred to by the term clinical trials. Please treat those terms as essentially synonyms. What I want you to do when you're confronted with these questions is first make this preliminary decision. In this question I'm reading, do I have an observational study or an experimental study? Now the reason for this is very simple. As I've tried to analyze why people get these questions wrong, I found out most often the reason is you give me an observational answer when I gave you an experimental study, or you give me an experimental study answer when I gave you an observational study in the question. So by making this preliminary decision, is it observational, experimental, you can channel yourself towards a set of answers and avoid some of the wrong answers. So how do I know something is an observational study? How do I know it's observational? What's the main thing you're doing in an observational study? Yeah, that's easy. Observing, right. You're simply watching and recording what happens. What makes something, by contrast, an experimental study? Simple. There is an intervention. Intervention is when we do something and we're testing what we do. Give a drug, do a medical procedure, provide direction in terms of exercise or activity. When we're modifying people's behavior, that's an intervention study. When we're merely observing what people are doing, that's an observational study. What we're going to do is walk down through talking about each of these types of study designs, starting first with observational studies, and then move over and talk about the intervention studies, that is, the clinical trials. I'm going to present observational studies to you as a list, but I don't want you to see it as a list. I want you to see it as a sequence, a rational sequence, where one study naturally builds on the foundation laid by the previous type of study. Try to illustrate this as we start off with the most basic of observational studies, the so-called case report. In a case report, you're getting a description of a single patient. N equals 1 in a case report. A case report provides a description of the patient's past, the present symptoms, and any outcome or prognosis that is known about the patient. N equals 1, a case report. Now, a case report seems so basic, it doesn't even really seem to be a study, does it? The reason why we list this as a study is it's the first step in our knowledge progression, in our knowledge process. What we know from a case report is that this constellation of things did happen empirically. And since they can happen, that tells us that they could happen again. In other words, a case report lets us know what is possible in the world around us. The first time we ever knew about AIDS in the United States, somebody published a case report, an important step in the communication about this new disease. The British medical journal The Lancet publishes a case report in every issue. Why? They consider this basic preliminary conversation crucial as we learn, develop, and expand our knowledge. But there's a problem in a case report. In a case report, we only have one patient. And so when I look at what this patient presents, I don't know what is crucial for the disease as opposed to be idiosyncratic to the patient. The way we're going to get a sense about separating out unique personal qualities from disease is to step up from a case report to a case series. In a case series, we're simply looking at more than one patient. The differential between case report and case series is simply sample size. N equals 1, case report. N equals greater than 1, case series. What we're doing in a case series is grabbing together a bunch of patients, all of whom we believe have the same disease or syndrome, and then we're looking at, well, what is common, what is shared within that set of people that we're looking at. By doing that, we get to leave aside things that are unique to one and focus on the things that are common to all. It's from this case series that we're going to get the list of diagnostic criterion that you're going to learn and memorize to make your diagnosis of the patient. In other words, when you read Harrison's and it says, here's how you're going to diagnose the patient, this is where we got that information that you see in Harrison's. It's all about the shared criterion we got from a case series. Now, what you get from a case series, therefore, is a clear sense about what are the common shared elements of people that have the disease. But we're missing something here. What we're missing is a comparison group. In other words, with a case series, we can say how diseased people are alike, good thing. What we can't say is how diseased people are different from non-diseased people. There is no external comparison. Nonetheless, having a simple, clear list of criterion to diagnose the disease is another good, important step up in our knowledge process. What's next? Well, I don't know about you, but the next thing I want to know is how widespread is this disease we're talking about? Is this something that's relatively common or relatively rare? And the language I hope you're all used to, are we talking horse or zebra here? Well, the way we're going to answer that is to do a cross-sectional study. Now, cross-sectional study has a synonym. It's also known as a prevalence study. What we're doing in a cross-sectional study is reaching out at a single point of time and assessing who has and who doesn't have the disease, and at the same time we're doing that, what other qualities might go along with having or not having the disease. What we're getting, therefore, in this cross-sectional study is, of course, a measure of prevalence. Who's got it, who doesn't, and what factors might be associated with it. In this cross-sectional study, in addition to prevalence, are we also getting a measure of incidence? Well, the answer is, of course, no, because we're simply assessing at one point of time who has or who doesn't have the disease. We have no information collected that tells us when the disease began or anything that lets us count exactly when occurrence started. In this cross-sectional study, in addition to prevalence, do we also have a measure of causality? Well, no, we don't really have that either, because all the information we're collecting is collecting at the same moment in time, and so we can't get a temporal sequence which is essential for determining causality. Remember that old saying, which came first, the chicken or the egg? That's a cross-sectional problem. I have chickens, I have eggs, but I can't really comment with any clarity about which comes first. So, in my cross-sectional study, no incidence, nope. No causality, nope. But I do get prevalence, an important step up now in my knowledge process. I get a sense of how common or rare the disease is, and I might also get a sense of whether it's concentrated in certain segments of the population versus others. Now what? Well, once I have a sense about prevalence, now I want to step up to getting a sense of what causes, facilitates, or maybe even produces this particular disease. In order to get that information, we next step up to a case control study. Now you're in luck here, because the name is the definition. Case control study describes exactly what we're doing. We're taking cases, people with disease, comparing them to controls, people without disease. And then we're looking backwards in time, retrospectively, for the presence or absence of any associated risk factor. The real world is not this simple, but the USMLE is. For your purposes, a case control study is always a retrospective study. We begin classifying disease, they already have it, non-disease, they don't have it, and then we look back in time for any precursors or risk factors that we care to imagine and that we're able to identify. In this case control study, do I get a measure of incidence? Yes or no? The answer, of course, is no. Because all I do is start with people that have disease compared to people that don't have disease, and I'm looking backwards in time. I'm not able to see the onset of disease in any sort of reliable way. In this case control study, do I have a measure of prevalence? Well, no to that as well. Because I'm selecting in people, I'm not assessing what's out there in the population. I know how many people I have in my study, but who's in my study is not an accurate reflection of the prevalence in the general population. But that's okay. I already got prevalence, remember, from my case control study. Do I have a measure of causality? Yes, I do. In fact, that's the key point to doing the case control study. Case control study gives me really quick information about causal agents, or at least facilitating agents for the disease. Really quick. Why? Because the information I need already exists. I don't have to wait for anything to happen. The only rate-limiting step here is how quickly I can go back and get the information and then analyze the information that people tell me. This is a case control study. Understand how the analysis of this case control study works. I have people with disease and people without disease. What I'm going to do is look at what are the common features, what is shared within the people that have the disease, but what is dissimilar from the people without the disease. I'm going to look at what's shared within the disease, but dissimilar from the non-disease. In other words, this is brute empiricism. There is no theory needed here. All we're going to do is try to detect this simple pattern. What do they have in common that is different from what they have, the non-disease people? Using this technique, we can get a fairly quick and dirty but useful index about what are causing or facilitating issues for a disease. Let me try to illustrate this with a real-life scenario, one of my favorite actually. In the year 1991-92, a cholera epidemic swept across South America. Started in Peru, headed down over the Andes, ran across the Amazon basin, hit the Atlantic coast in about 6 months. And you know, we couldn't figure out where this was coming from. Now come on, we've known for over a century that when you have cholera, it's about a contaminated water source. You find the water source, you deal with the contamination, the cholera will simply go away. But this outbreak of cholera was so widespread, we couldn't figure out what was a common water source to focus on. People were getting the drinking water from so many locations, from so many different areas, we couldn't find out what was the source of cholera. How do we solve the problem? The way you would in an exam question, a case control study. What we did was gather together a bunch of people that had cholera and a bunch of people that were cholera-free. And then we interviewed both sets. Interviewed them about what? Frankly, about everything. Where they went, what they did, who they talked to, what they ate, where they traveled, everything we could about their lives. And then when we've exhaustively gathered information from both sets, we excused the people in the study, and then we sat down to analyze their data, looking for, remember, what is in common within the disease group but dissimilar to the non-disease group. As we did that analysis, as time unfolded, we discovered there was one and only one factor that all the disease people had in common that almost none of the non-disease people had. You know what it was? Mangoes. People who had cholera loved mangoes. Mangoes, ate them all the time. People who did not have cholera hated mangoes, never touched them. Mangoes? Cholera? Sure. You go down to the big cities in South America on the street corners, you can buy, all right, let's be honest, whatever you want, but you can also buy mangoes. And before these mangoes are shipped to the street vendors, so they're nice and shiny and you want to buy them, they are washed before they're shipped. See where this is going? Mangoes were indeed spreading the cholera. The source of water that was used to wash the mangoes was the source that was contaminated. We figured out what this contaminated source was, shut it down, and then there was no more cholera all across South America. Now here's why I love that example, because I could have you sit down in a room for hours and tell you I'll let you out when you tell me the source of the cholera outbreak, and no one's going to knock on the door and say, hey, it's the mangoes. It just wouldn't occur to you. Notice what happens here in this case control study. Put aside your preconceptions. Let's exercise brute empiricism. What do all these people have in common that hardly any of these people have in the control group? Then that's got to be a key governing issue. So, in a case control study, no incidence, nope. No prevalence, nope. But we do get information about causality. Okay, with that in place, we then step up to the last in our sequence, the cohort study. A cohort study is in some sense the capstone for the list of studies that we've just gone through. It is the final observational study, is the one that gives us, well, the best, most reliable data of all of the cohort studies. Way to remember cohort studies is essentially the exact opposite of a case control study. A case control study, you recall, we begin with disease versus non-disease, and then we look backwards in time for the presence or absence of a risk factor. In a cohort study, we begin with people that have or don't have a risk factor, and then we follow them forward, usually in real time, looking for the development or non-development of disease. In a case control study, disease versus non-disease is our starting point. In a cohort study, disease versus non-disease is the ending point. A case control study you recognize is retrospective. A cohort study you recognize is therefore largely prospective. I say again, the real world is not this simple, but the USMLE almost certainly is. It's all about a prospective study, which is a cohort study. Okay, in this cohort study, if you're following me, do I have incidence rate of disease? Well, yes, I do. Because, and by the way, it's the only study that gives me incidence rate of disease, because I'm watching disease actually develop. I'm not guessing when it started. I can literally see it as it occurs. In this cohort study, do I have a measure of prevalence? Well, no, I don't. Because, well, I'm going to get the prevalence that grows out of incidence, right, about that. What I'm not going to get is all the other people in the population that already have the disease, so I don't have all the pieces I need to accurately talk about population prevalence. In this cohort study, do I get a measure of causality? Absolutely yes. And, I hasten to add, the best assessment of causality of anything we've talked about so far. See, in a case control study, I'm looking at what is and going back to infer a connection to something in the past. It's like if I see an oak tree, I can connect it back to the acorn. But in a cohort study, I don't just have the connection, I can watch the process unfold. I can watch that acorn grow into be the oak tree. I not only see there's a connection, but I can actually observe as the whole process unfolds literally before my eyes. This is a cohort study. Cohort study, incidence yes, prevalence no, causality almost certainly yes. Now the cohort study is felt by most people to be the best of all the observational studies. It gives us the most reliable, the most, well, likely to be sustained over time set of research findings. So here's a thought. If the cohort study is best, then why do we do all the others? Isn't the idea in medicine to just do what's best? Why do we spend our time on case report, case series, cross-sectional case control study? Why don't we just do the cohort study? Well, the answer is, of course, the cohort study takes a lot of time and therefore it's very expensive. And before we spend all that time and all that money on the study, we want good preliminary evidence that it's worthwhile use of our time and energy. Hence, we do the sequence to make sure that when we actually do the cohort study, it's going to be worthwhile and we'll be glad that we spent the time and energy doing that. I mean, consider somebody who spends their entire career, 20 years, conducting a cohort study, at the end of which they analyze the data and they decide, never mind, there's no difference. How embarrassing would that be? Your entire life spent on something where you ended with a zero at the end. We're going to do preliminary work to assure ourselves that a cohort study is worth time and energy. Okay, now the reason I want you to think about these as a sequence is, one, it's easy to remember the sequence than loose ideas of studies running around, but two, there is a reason for the sequence. Whenever you do research, I want you to go out and do a literature search first, find out what's gone before, and then do the next step in the knowledge process. So if you want to do research in a particular area, sir, and you do a literature search, you find out there's a whole bunch of cross-sectional studies done, 6 of them. Don't do another one. If you want to do research in this area, you have to step it up to the next level. You have to do a case control study. This is how our knowledge advances. We don't simply go back over the same ground over and over again. We take a step forward when we're ready to take that step. Of all of these observational studies, focus on the case control study the most. Now why? Well, first, because I think of all these studies, it's the one you're most likely to be tested on your Step 2 CK exam. But secondly, if you do any research at all yourself, doctor, the kind of research study you're most likely to participate in is a case control study. It's easy for clinicians to do a case control study. As a clinician, you already have cases. All you have to do is go out and find controls, and voila, you have a study on your hands. So case control study is the one I want you to be most comfortable with out of all the ones we've talked about. Now, you need to be able to identify what type of study it is you're looking at, but in addition to that, you need to be able to answer the second question, namely, how do we analyze data that come from these different research studies? Now, if you're reading through the description provided in a question about these studies and you get confused about which type of study it is, although it's not the only criterion, time by itself should be enough for you to nail down the type of study we're talking about. Quite simply, if you're going forward in time, prospectively, it's a cohort study. Same point of time, cross-sectional study. Going backwards in time, retrospective study. I remind you again that the real world is not this simple, but usually the USMLE is, so time alone should be sufficient criterion for you to nail down the type of study design. Now, in addition to knowing which type of study design we're talking about, you also have to have a sense of how to analyze data that come from each of these research study designs. We're going to first take up how we analyze data that come from a cohort study. Now, you remember a cohort study? Cohort study, we're gathering the data prospectively. And the data that we're getting is incidence data. It is, again you recall, the only study that gives us incidence data. And so, the analysis techniques we're about to talk about can only be used in a cohort study. If you have another kind of study, wonderful, but you can't use these analytic techniques. The two analytic techniques I want you to be familiar with are first, relative risk, and secondly, attributable risk. Attributable risk is also known by the term absolute risk reduction. That's basically a synonym. Attributable risk, absolute risk reduction, they're essentially the same thing here. Relative risk and attributable risk both use the same kind of data taken from a cohort study, but both do different things with the data. The key thing to remember is simply the mechanics of the mathematics. For relative risk, you're going to divide. For attributable risk, you're going to subtract. Relative risk divide, attributable risk subtract. You're given here on the slide and in your syllabus the classic definition of relative risk. It's the ratio of the incidence rate in the exposed divided by the incidence rate in the unexposed. Exposed divided by unexposed. That's the classic and traditional definition of relative risk. But there's a problem with that definition. The problem is sometimes deciding what is the exposed group or deciding what is the unexposed group can by itself be very confusing. I mean, consider. Here we have some data that I collected from a neighborhood in Chicago where I'm from several years ago. In that particular neighborhood, I found infant mortality in whites was 20 per 1,000 live births. In that same neighborhood, I found infant mortality in blacks was 10 per 1,000 live births. Well, the question is, of course, which is the exposed group? What do you mean here? Exposed to being white? Not exposed to being white? Isn't that, shall we say, linguistically awkward at best? So, here's an idea. Since exposure, non-exposure doesn't clarify, get rid of it. Forget about exposure, non-exposure. Let's simplify. What's a relative risk? Easy. It's a ratio of two incidence rates. One incidence rate divided by another incidence rate. That's it. A simple calculation. One on top, one on the bottom, and you get the answer. Wait, how do I know which one goes on the top and which one goes on the bottom? That's easy. Listen to the question. If the question says, what's the relative risk of white versus black? Then white on top, black on the bottom. Relative risk computes to 2. If the question says, what's the relative risk of black versus white? Then black on the top, white on the bottom. Relative risk of 0.5. And now, having done that, look carefully and admit to me, it doesn't matter how you do the ratio. It doesn't matter whether you put white on top or black on the top, because the result you get gives you the exact same information. Because to say a white child has twice the chance of dying in the first year of life, or to say an African American child has half the chance of dying in the first year of life, are logically equivalent statements. I've said the same thing, I merely said it differently. How do I decide which way to compute my relative risk? It's all about what kind of instructional point you want to make. If I wanted you to walk out of here thinking that whites were more at risk, I'd put whites on the top and blacks on the bottom, relative risk of 2. If I want to have you walk out of here thinking blacks were somehow protected, I'd put blacks on the top and whites on the bottom, relative risk of 0.5. Either way you do it, you're getting the same information, just with a different emphasis. It's sort of like deciding which word to accent as you're talking your way through a sentence. What am I getting from this relative risk calculation? Simply, I'm getting a multiplier. I'm getting a multiplier that tells me the answer to the question, how much more likely? 2 means twice as likely. 3 means 3 times as likely. 0.5 means half as likely. What you're getting in a relative risk calculation is essentially a comparative probability, telling you, comparing between the two groups, what's the relative chance, what's the relative probability, what's the word we use is relative risk. Attributable risk is something different. Attributable risk, we're not doing division, we're doing subtraction. And what we're subtracting should be straightforward here. We're always going to subtract the smaller number from the larger number. Using the data on this slide, it's going to be 20 per thousand minus 10 per thousand gives us a computed attributable risk of 10 per thousand live bursts. Now notice, you're getting different information here, right? You're not getting a comparative probability, you're not getting a multiplier, you're getting, well, basically here, a body count. How many additional dead babies are we going to have per thousand as we compare between the two populations here? In short, we're getting an answer to the question not how much more likely, but how many more cases comparing between the two groups. Probability is one thing, cases is something else altogether. Now, think for a second. As a practicing primary care physician, which one of these two is probably of most concern to you? Well, I'm going to suggest it's going to be attributable risk. Because as a physician, you don't treat probabilities, you treat patients. And attributable risk here tells you how many additional dead babies you're going to see if you go from practicing where it's mostly black to going to practice where it's mostly white. There's another way I want you to think about the difference between these two analysis techniques. It's a concept I'll introduce now that I'll elaborate a little bit more on later as we go into biostatistics. There's a distinction I'd like you to keep in mind between 1, statistical significance, and 2, clinical significance. Statistical significance simply asks a question, is there a difference? Clinical significance takes it another step further and says, does the difference that you find actually matter? Well, it's a crude but useful way to separate out these two techniques, relative risk and attributable risk, that relative risk answers the statistical significance question. Is there a difference? It's from relative risk that you're going to get a p-value, for example. It's from relative risk you're going to be able to decide whether or not the two groups are different. Attributable risk gives you more of what I was referring to as clinical information. It tells you concretely how much the difference matters. It tells you here, concretely, how many additional dead babies you're going to see. It lets you assess not just probability, but lets you assess the actual real human toll and consequence. How are we going to analyze data that come from a cohort study? Simple. Since a cohort study is incidence data, we have two techniques, relative risk and attributable risk. What are the key things to remember here? Relative risk you're going to divide. And the result of that division is a simple multiplier that tells you how much more likely. In attributable risk, also called absolute risk reduction, we're going to subtract. What are we going to get from this? Simple. Comparative body count. How many additional cases do we have in one group versus the other? If on the exam you're not sure which one of these to do, relative risk or attributable risk, default to doing the relative risk. It's not a better technique, it's just the one you're more likely, I believe, to be tested on. Now that's how we analyze data that come from cohort studies, but we can't use those techniques to analyze data that come from case control studies. Why? Well, remember, relative risk and attributable risk are limited to only incidence data. And you also remember that in a case control study, there is no incidence data. Therefore, relative risk is not a possibility. What we're going to use instead is something called an odds ratio. Not relative risk, but odds ratio. Now simple pairing. Case control study is analyzed by an odds ratio. Odds ratio is used to analyze a case control study. Case control, odds ratio. Odds ratio, case control. 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 That should be a pre-wired association. You don't reach out for that. It ought to already be there in your head, because let's be clear how the exam question will come at you. They will not say, here's a case control study, analyze the data. They will say, here's a study, analyze the data. You're going to have to read and recognize it's a case control study and then realize you therefore must do an odds ratio in order to complete the analysis. So before we actually look at how we're going to compute an odds ratio, let me just pause here and insert a different issue that I want you to look at with me. I'm presenting to you here a simple 2x2 table on the screen before you. This 2x2 table is about people with lung cancer, no lung cancer, smokers, and non-smokers. And the simple question is, what type of study design is this we're looking at? Is this a case control study, a cross-sectional study, or a cohort study? Well, the key issue is you can't tell for looking here. Now follow me on this. Suppose right now I went out and I measured who was or was not a smoker, and at the same time whether somebody had or didn't have lung cancer. That would be a cross-sectional study, and I could present the data just like this. Or suppose I went out and I found people that were smokers, people that were not smokers, and I followed them forward over the next, well, let's say 5, 10 years to see who did and did not develop lung cancer. That would be a cohort study. I could present the data just like this. Or suppose I went out right now and I selected for myself people that had lung cancer or people that did not have lung cancer, and then look back in time in their history to see whether or not they had or had not been smokers. That would be a case control study. The point is, you can't tell what type of study it is by simply fixating on the 2x2 table. What tells you the type of study is the verbal description that comes with the table, not the 2x2 table itself. Now this is important because we find on many exam questions, people fixate on that 2x2 table and you don't actually read what they did to get that information. The phrase we like to use here is it's not the data display that matters, it's the data derivation. In short, what matters is not what they're showing in the table, but what they did to generate the information that they are able to show you in the table. You're going to decide the type of study by looking at how the data was generated, not the data presentation. Okay, with that point made, and a wave of my magic wand, bling, I've now converted this same 2x2 table into being a case control study. How do you know it's a case control study? Because I'm telling you it is. That's the only way you know. I'm telling you it's a case control study, therefore you know what I'm talking about. So, in this case control study, how are we going to analyze the data? Well, you remember we're going to do an odds ratio. Let's try to illustrate what we mean by an odds ratio. First, odds. What are the odds of being a smoker given that you have lung cancer? Well, that's easy. That's going to be simply A divided by C. Why? Because that's what we mean by odds, the direct ratio of the two cells, A divided by C. Please note, not A divided by A plus C, but A to C directly. What are the odds of being a smoker given no lung cancer? Well, that's easy as well. Simply B divided by D. Notice once again, not B divided by B plus D, B to D directly. Well, wait, if that's an odds, A divided by C, and that's an odds, B divided by D, what's the odds ratio? Well, that's easy. A divided by C divided by B divided by D. Divided by, divided by, divided by. Now, that's correct, but isn't that just way too many divided bys? So you're in luck, because by the magic of algebraic transformation, we're able to take this, let's call it definition formula, and convert it into being a much easier to use computational formula, namely AD divided by BC, and that's the formula to memorize and learn. AD divided by BC is your formula for doing the case control analysis, which we call odds ratio. Now, how do you remember this formula for the odds ratio? Simple. Let's look at it one piece at a time. First, the numerator. Look at what's on top. What's on top is AD. Now, stand with me and just free associate. What do you think of when I say AD? AD. Well, in the Christian nomenclature, AD, this is the year 2008 AD, Anno Domini, AD. Okay, with that headset in mind, AD, now let's look down at the denominator, BC. Right, it means in Latin before Christ. What's the odds ratio? Simple. Present time divided by former time. AD divided by BC gives you the odds ratio. Okay, so all we have to do to complete this system is make sure you know which cell's A, which one's B, which one's C, and which one's D. Now, actually, that's easy, because all you have to do is find the A cell, and everything else is derived from that. And the A cell is the one that you probably care about the most. Here we have a study about smoking and lung cancer. Well, the A cell is the convergence of those two together. Disease with risk factor, where they converge, that's always going to be your A cell. D stands for diagonal. The diagonal cell is going to be your D cell. And then B and C, it's what's left over. Wait a minute. Which one's B and which one's C? Why do you care? You're multiplying them together anyhow. It doesn't matter if you screw up which one's which. Because the formula, AD over BC, is easy to derive once you get the A and the D cell nailed down. B and C is simply what's left over. AD divided by BC. We sometimes talk about this as the cross products of the cells. That is, I multiply together the diagonal cells and then do the division in order to get the odds ratio. Sometimes we say X marks the spot when it comes to the odds ratio, because you can see it's the diagonals, it's the cross products of the cells that we use in our calculation. Let's go ahead and try an example together, shall we? Here we have a presentation of a case control study. You know this is a case control study because I'm telling you that it is. Here we have no colorectal cancer, family history of colorectal cancer, no family of history of colorectal cancer. All right, in this 2x2 table, quick, which is the A cell? Well, that's going to be 60. Because even though I rotated the table on you, it's still easy to find the A cell. It's disease with risk factor, colorectal cancer with family history. Therefore, what is the D cell? Well, that's easy. The D cell is going to be 200. And so the odds ratio is calculated as 60 times 200 divided by 120 times 20. What you get, if you actually sit down and do the math all the way to the end, is an odds ratio equal to 5. Now, first of all, very often on the exam, simply setting up the problem is sufficient. That is, if you got 60 times 200 divided by 120 times 20, that would be enough to pick your answer out of the answer choices given. But let's talk about what it means when we actually get an odds ratio number. Odds ratio equals to 5. What does that mean? Well, you can hear it read one of two ways. Both are correct, but one is best. One way you're going to hear this read is, if you have a family history of colorectal cancer, you're 5 times more likely to have it yourself. And that's okay, but it's not best. Best is, if you have colorectal cancer yourself, you're 5 times more likely to have had a family history. Why is that best? Because that's the data you collected in your case control study. I know, in your heart of hearts, you want to take family history and predict colorectal cancer, but that's not the data you collected. You took colorectal cancer and went back and found family history. And so, read it like that. What are we getting with an odds ratio? Easy. It's the chance of risk given disease. It's how strong the risk factor is given that somebody has the disease. Now understand, what we're going to do in our case control studies is look usually not at a single risk factor, but multiple risk factors in the past. We're going to compute an odds ratio for each one, and the largest odds ratio is therefore the, as you've heard the term, strongest risk factor. We talked to you about which is the strongest risk factor. This is simply how we got that information. It's the one in the case control study that gives us the highest odds ratio. We next come to a simple table, and this table is a summary of content that we've already talked about together. I simply want to walk you through a couple of the details by way of review here. Take a look down at the bottom 2 rows of the table. Notice in a cross-sectional study, we're looking at association, not causality. We're looking at how things go together. Maybe a risk factor co-occurs with the disease, but since there's no temporal sequence, we cannot talk about causality. Notice in a case control study, we get to talk about many risk factors and how they might converge on a single disease. Since we're classifying people's disease, non-disease, we look back in their history for any risk factors that we care to. If I want to look at lung cancer versus no lung cancer, I look in the history for smoking versus no smoking, exercise versus no exercise, dietary issues versus no dietary issues. Any number of risk factors can be analyzed in relation to that simple classification, disease, no disease. By contrast, in a cohort study, I get to see how a single risk factor might contribute to multiple different disease outcomes. Since the key classification of cohort study is risk versus no risk, I can then follow people forward in time looking at, well, any outcome that I care to. So if I'm classifying people that are smokers and non-smokers and following them forward, I can look at how that smoking variable might relate to lung cancer, pancreatic cancer, heart disease, diabetes, any medical outcome I might want to. Please notice every one of these outcomes is, of course, an incidence rate. How am I going to analyze data that come from a cross-sectional study? I didn't mention this before, but I will now in passing. Most often we're going to do something called a chi-square analysis. We'll talk about that in more detail when we get back into biostatistics. How are we going to analyze data that come from a case control study? That's easy. Case control, we use an odds ratio. The odds ratio, you recall, tells us the chance of the risk factor given the disease. How are we going to most likely analyze data that come from a cohort study? That's easy as well. We're going to do a relative risk calculation. Relative risk calculation, which tells us for the incidence data in the cohort study, how much more likely is the incidence in one group versus another group. We have another table here I want to draw your attention to, which compares and contrasts case control versus cohort studies. This is one of the primary nexus of confusion for people as they're doing these different types of observational studies. People seem to get confused about whether we're talking about a case control or cohort study. Let me walk down through some of the key differentiating criteria. In general, a cohort study takes a much larger number of subjects because it must have a large enough pool of subjects to see the incidence arise out of that pool. Case control studies, we get away with a much smaller pool of subjects because I can focus on gathering in people with disease and then just comparative people. I needed a lot fewer subjects to do that particular comparison. The cohort study costs a lot more money and takes a lot longer to do. It gives us better data, but there's some cost involved in that. The case control study is much lower cost and it evolves in a relatively short amount of time. So if you're doing a disease outbreak investigation, trying to decide why people in a given community have a disease, clearly the right choice is a case control study because it gives you the information quickly when time is of the essence. Case control study looks at how multiple exposures contribute to one disease, as we said before. A cohort study looks at how one risk factor, exposure, might contribute to multiple different diseases going forward. We use a case control study, whatever the prevalence of the disease might be, whether it's high or it's low, we can concentrate our focus so it doesn't matter with a case control study. We can use a cohort study only when we have a very high incidence disease. If the incidence rate is very, very low, then the number of people we'd have to follow to get the requisite number of cases for our analysis is simply too unwieldy to be beneficial. This finishes our conversation about observational studies. Remember, the main thing we're doing in an observational study is we're observing. We're sitting, we're watching, we're gathering data and information. What differentiates it from the other class of study, the experimental studies, is experimental studies are about an intervention where we're testing the effects and hopefully the benefit of that intervention.